Welcome back to the deep dive. We are shifting gears a bit today. Usually we explore a topic for curiosity's sake, pulling threads to see where they lead. But today we have a very specific mission. We are strictly in exam mode.
Yes, absolutely.
If you are a postgraduate student, specifically an anesthesia resident, prepping for your A&D finals, whether that's the Gujarat University pattern or really any major board exam, this session is designed explicitly for you. We're not just browsing, we are studying.
That's right. We aren't just skimming the surface today. We are treating this as a high-yield revision tutorial. Imagine you're the candidate, I'm the senior faculty or the examiner sitting across the table, and we're going to dissect a topic that is an absolute guarantee in the exam.
A guarantee.
You cannot go into that hall without mastering this. It's just too fundamental to obstetric anesthesia.
And it is the heavyweight champion, isn't it? It shows up as a long case, it pops up as a short note, and it is a favorite trap in the viva voce.
It's the full packet.
We are talking about diabetes and pregnancy. We've got a massive stack of sources here. We're pulling from the gold standards. Miller's Anesthesia, Morgan and Mikhail, Yao and Artuzio, and we've also got those invaluable exam-focused review notes from Kashiket Jothanath and the standard long and short cases texts.
It's a huge topic, and to survive the exam, you need to be able to pivot. You have to jump between the endocrinology, the obstetrics, and the pure anesthetic management.
Right.
If you get lost in the sugar numbers and forget about the airway, you fail. If you focus only on the airway and you forget the fetus, you fail. It's all about integration.
High stakes. I love it. Okay, let's start with part A, the fundamentals. Let's set the scene. I'm sitting in the exam hall, pen in hand, and I see the 20-mark question. Classify and discuss the pathophysiology and anesthetic management of diabetes in pregnancy. How do I frame the introduction to immediately grab the examiner's respect?
Okay, good question. You need to open with a definition that is precise but also immediately flags the clinical relevance. Don't just say high sugar.
Too simple.
Way too simple. You define it as a metabolic disorder characterized by hyperglycemia due to an absolute or a relative insulin deficiency. But then you immediately hit them with the epidemiology. It is the most common medical complication of pregnancy.
Right. Miller really emphasizes that. And looking at the long and short cases text, it suggests framing it as a multi-system disease right from the very start.
Exactly. In your opening paragraph, you state clearly, this is a multi-system disorder affecting the maternal vascular, renal, and autonomic systems, and critically, it creates a hostile intrauterine environment for the fetus. For us, as anesthetists, this translates to what I call the triad of risk.
The triad of risk. Okay, what's that?
A potentially difficult airway, hemodynamic instability due to those autonomic issues, and the constant risk of fetal distress. If you write that in the first 5 minutes, or you say that in the first minute of your viva, the examiner knows you get the big picture.
So you're not just looking at a glucometer.
You're not just looking at a glucometer, you're looking at a complex patient and a complex fetus.
That triad of risk is a great mental hook. Okay, let's move to the classification.
Yeah.
This is usually where the first short note question comes from, or maybe the first thing they ask in the Viva to warm you up.
Right.
We have GDM and we have pregestational diabetes. What's the high-yield breakdown here for the exam?
You must distinguish them clearly. Gestational diabetes mellitus, or GDM, is carbohydrate intolerance of variable severity with onset or first recognition during pregnancy.
The key word is during.
During is the absolute keyword. It doesn't matter if they need insulin or just diet control. If it's found for the first time in pregnancy, it starts as GDM.
Whereas pregestational is the patient who walks into the clinic with a known history of diabetes.
Correct. And that splits into your classic type 1 and type 2. Type 1 is absolute insulin deficiency that's usually autoimmune, beta cell destruction. These are your brittle diabetics, the ones who are really prone to ketoacidosis.
Okay.
Type 2 is, well, it's a dual problem. It's insulin resistance plus a secretory defect, and it's very often associated with obesity and metabolic syndrome.
Now, the Kashik source brings up Casilla-White's classification. Is that still relevant for the exam? It feels a bit old school with all the letters from A to T.
It is very high yield for the classification section of a theory answer. You don't need to memorize every single letter from A to T unless you have a photographic memory, but you absolutely must know the GDM subtypes from that classification.
Which are?
Class A1, that's diet controlled, with a fasting glucose under 105 milli-GDL. Then you have class A2, which is more severe. It requires medication, insulin, or oral agents because that fasting glucose is over 105.
And why does the examiner care if I know whether it's type 1 or type 2? Is it just academic labeling?
Not at all. It's clinically vital. It tells you the end organ risk profile. If you tell me the patient is type 1, my brain immediately starts worrying about long-standing microvascular disease,
Like what?
nephropathy, retinopathy, and that stiff joint syndrome we'll get to. DKA is also a much bigger risk.
And for type 2?
With type 2, I'm thinking macrovascular disease, hypertension, morbid obesity, and a much higher chance of coexisting preeclampsia. The classification isn't just a label, it's a roadmap to the patient's potential complications.
So the classification basically predicts the problems we need to hunt for during our pre-op assessment.
Precisely. It sets the stage for your entire anesthetic plan.
Okay, that makes sense. Let's move to Part B, Pathophysiology. This is often asked as a standalone short note, Pathophysiology of the diabetogenic state of pregnancy. Miller uses this really interesting phrase, accelerated starvation. Can we unpack that? Because usually when I think of pregnancy, I think of weight gain, not starvation.
It's a fascinating physiological paradox, isn't it? You have to view the fetus, biologically speaking, as a very effective parasite.
Oh, parasite, okay.
I mean it in the kindest way. But it is an obligatory glucose consumer. It siphons off glucose and amino acids from the mother continuously, 24 hours a day, regardless of whether the mother is eating or sleeping.
So the mother's baseline fasting sugar actually drops because of this constant drain.
Exactly. Because of this continuous fetal consumption, the mother's fasting blood sugar is often lower than in a non-pregnant state. That's the starvation part of the phrase.
But then something else must be happening to cause the high sugars of diabetes.
Yes. To counteract that and ensure there is enough food for the baby, the placenta orchestrates this state of profound insulin resistance. It's trying to keep sugar in the blood available for the fetus to use.
So who are the bad guys here? Which hormones are driving this resistance?
The primary antagonist, the main villain of the story, is human placental lactogen, or HPL. You might also see it called human chorionic somatomammotropin.
And that's produced by the placenta.
Yes, entirely by the placenta. It mimics growth hormone, and it's a powerful blocker of the mother's insulin. It basically tells the maternal cells, don't take up this glucose, save it for the baby.
And it's not alone, is it?
Yeah, not at all. You've also got cortisol, which peaks around 26 weeks and increases gluconeogenesis, making new sugar in the liver. And then progesterone and estrogen also contribute to these anti-insulin effects. It's a hormonal cocktail designed to raise blood sugar.
So the mother's pancreas just has to work harder to overcome all of this.
Much, much harder. A normal pregnancy requires 1.5 to 2.5 times the normal insulin secretion just to maintain normal blood sugar. If the mother's pancreas can't meet that demand, boom.
You get gestational diabetes?
You get GDM. It's like a metabolic stress test for the pancreas. If there's any weakness, pregnancy will find it.
And this metabolic shift, this leads back to that accelerated starvation state where she starts breaking down fat.
Exactly. Because the maternal cells are starving for glucose due to the resistance, and the baby is taking what's there, the mother's body shifts to lipolysis. It starts burning fat for fuel.
Which produces ketones.
Right. It releases free fatty acids and ketones into the bloodstream. And this is why a pregnant diabetic is so incredibly prone to developing ketoacidosis. Their buffering capacity, their bicarbonate level, is already lower because of the normal respiratory alkalosis of pregnancy. They just can't handle that extra acid load.
And that brings us to a critical Viva trap. Differentiating diabetic ketoacidosis, DKA, from simple starvation ketosis.
Yes, absolutely critical. The simple answer is that in starvation ketosis, the blood sugar is low or normal. In DKA, the sugar is high.
But there's a catch in pregnancy, right?
There's a huge catch. You can have euglycemic DKA. That's where the sugar isn't spectacularly high, maybe only 200 or 250 milli-GDL. But the patient is profoundly acidotic and full of ketones.
Wow.
So you cannot rely solely on the glucometer to rule out DKA in a pregnant woman. You have to check for ketones in the urine or blood, and you need a blood gas to check the pH. It's a trap many people fall into.
What about electrolyte disturbances? What should we be thinking about there?
Well, the hyperglycemia causes an osmotic diuresis. They're losing a lot of water, so they're dehydrated. But specifically, you have to think about potassium.
Okay.
Insulin is what drives potassium into cells. If you lack insulin or you're resistant to it, potassium tends to stay out in the blood. But with the ongoing osmotic diuresis, they're losing huge amounts of potassium in their urine. So their total body potassium is severely depleted.
Even if the serum K+ level on the lab report looks normal.
Especially if it looks normal. A normal serum potassium in the face of acidosis and hyperglycemia should make you very, very worried. It means their total body stores are dangerously low.
Okay. Moving on to Part C, maternal and fetal effects. This feels like the real core of the long answer in the exam. If you get that question, this section needs to be robust. Let's look at the mother first. What are the big red flags?
Preeclampsia is the big one. The incidence is 2 to 8-fold higher in diabetics. It's all about vascular endothelial dysfunction. If you have a diabetic parturient, you must be actively looking for signs of preeclampsia, hypertension, and proteinuria.
2 to 8 times higher? That's a huge increase.
It's massive. They're very closely linked conditions.
And polyhydramnios. That's excess amniotic fluid. Why does that happen?
It's a fetal problem, really. Fetal hyperglycemia leads to fetal polyuria.
The baby is peeing too much.
The baby is peeing too much into the amniotic sac. That overdistends the uterus. For the anesthetist, that means 2 things. 1, an increased risk of aortocaval compression, and 2, and this is crucial, a massive risk of uterine atony and postpartum hemorrhage, PPH, after delivery.
Because the uterus is like an overstretched balloon.
Exactly. It doesn't have the tone to contract down properly after the baby is out.
Infections are also mentioned frequently in the text.
Poor leukocyte function in a hyperglycemic environment. They are much more prone to wound infections, UTIs. This is why strict, almost obsessive asepsis during your spinal or epidural is absolutely non-negotiable.
Okay, let's talk about the airway. This is where the examiner will really lean in and pay attention.
This is pure anesthesia territory, the stiff joint syndrome.
Also known as diabetic chiroarthropathy.
Correct. Decades of high sugar levels cause something called non-enzymatic glycosylation of collagen. The collagen basically gets sticky and coated in sugar, making it stiff and waxy.
And this affects the neck.
It affects all the small joints, but the one we care about most is the atlanto-occipital joint. If that joint is stiff, you can't get the head extension you need for laryngoscopy. You simply cannot achieve the sniffing position.
And how do we test for it? There's a famous sign?
The prayer sign. It's simple and elegant. You ask the patient to press the palms of their hands together like they are praying.
Yeah.
If they can't flatten their fingers and palms completely against each other, if you see a gap because the interphalangeal joints won't extend fully, that's a positive prayer sign.
And that correlates with the difficult airway.
It correlates very strongly with the difficult intubation. If you see that gap, your internal alarm should be ringing. You should be reaching for the video laryngoscope before you even start.
That is a golden clinical pearl. Okay, let's switch our focus to the fetus. We hear the term macrosomia all the time. Why does the baby get so big?
It all comes down to the Peterson hypothesis. It's a beautiful piece of physiology. Maternal glucose crosses the placenta very easily through facilitated diffusion, but maternal insulin, which is a big protein molecule, does not cross the placenta.
So the fetus is getting a massive sugar load without the mother's insulin to control it.
Exactly. So what does the fetus do? It responds by making its own insulin. The fetal pancreas goes into overdrive, leading to fetal hyperinsulinemia.
And fetal insulin acts as a growth factor.
It is a potent growth factor for the fetus. It makes them lay down fat and grow their organs. You get organomegaly. This leads to a big, puffy baby, which in turn leads to problems like shoulder dystocia and birth trauma during delivery.
And what about the opposite problem? You mentioned congenital anomalies.
Yes, it's a first trimester problem. It happens during organogenesis. This is typically seen in pregestational diabetics who enter pregnancy with poorly controlled sugars.
What kind of anomalies are we talking about?
The most common are cardiac defects like VSD or transposition of the great arteries, and also neural tube defects. The specific one to remember for the exam, it's rare but it's a classic association, is caudal regression syndrome or sacral agenesis.
And then after the baby is born, we have to worry about the neonate crashing, right?
Neonatal hypoglycemia. It's a Viva favorite. The examiner will almost certainly ask you, why does the baby get hypoglycemic?
And the answer is?
The answer is, the baby was living in a high-sugar intra-uter environment, so its pancreas, with its hyperplastic islet cells, was pumping out huge amounts of insulin. Then you clamp the cord, the sugar supply is cut off instantly to 0.
But the baby's pancreas doesn't know that.
It takes hours or even days for the baby's pancreas to downregulate. So you have this state of high insulin with no incoming sugar. The result is severe, potentially dangerous hypoglycemia.
And finally, respiratory distress syndrome, or RDS. I thought stress was meant to mature the lungs.
Normally, yes. Cortisol helps with that. But here, that high level of fetal insulin actually interferes with cortisol's action on the type 2 pneumocytes. It blocks cortisol's ability to stimulate surfactant production, so lung maturity is delayed.
So you could have a huge macrosomic baby that actually has the immature lungs of a preemie.
Exactly. It's a dangerous combination.
Okay, we've laid all the groundwork. Now for Part D, anesthetic management. This is the practical how-to section. Let's start with the preoperative assessment.
Your history taking is absolutely key. You
Yeah.
need to know the type of diabetes, the duration, their current medications, insulin versus metformin, for example. But most importantly, you have to systematically assess for that triad of diabetic complications: cardiovascular, renal, and autonomic.
Let's break those down. Cardiovascular first.
You have to have a high index of suspicion for silent ischemia. Because of autonomic neuropathy, a diabetic might have a massive MI and feel absolutely no chest pain. A resting ECG is mandatory. You're looking for old Q waves or any acute ST changes. Check for proteinuria, look at the creatinine. Diabetic nephropathy affects drug clearance. You might need to adjust doses of muscle relaxants or other drugs.
And autonomic neuropathy. This seems to be the one that can really catch people out intraoperatively.
It's the silent killer in the OR. It manifests in a few ways. First, gastroparesis. The stomach doesn't empty properly, so even if they've been fasting for 12 hours, you have to treat them as a full stomach.
So a high aspiration risk.
A very high aspiration risk. Hemodynamically, they have a fixed heart rate. They lose their beat-to-beat variability. They don't get a compensatory tachycardia when their blood pressure drops. So if you give a spinal and the pressure plummets, the heart rate won't go up to help out. You can get sudden, profound hypotension or even cardiac arrest.
That's scary. How do we assess for that before we even go to the OR?
You ask them, do you get full quickly after eating? Do you get dizzy when you stand up? You can also look for a resting tachycardia on the monitor. And you must ask about hypoglycemia unawareness. Patients who don't get the usual warning signs like sweating or shakiness when their sugar drops because their sympathetic nervous system is shot.
Now for the million-dollar question. Glycemic control in the perioperative period. What are the targets? What are we aiming for?
This is a crucial point. Don't aim for normal. Aiming for a blood sugar of 80 is dangerous under anesthesia because you can't see the clinical signs of hypoglycemia. The patient can't tell you they feel unwell.
So what's the safe range?
The target is generally between 90 to 130 milli-GDL. Some guidelines might say up to 150. The absolute rule is avoid hypoglycemia at all costs. Hyperglycemia is bad, but hypoglycemia can kill or cause brain damage within minutes.
Okay. And how do we manage their usual insulin on the day of surgery?
On the morning of surgery, you omit the oral hypoglycemics. If they are on metformin, that should ideally be stopped 24 hours prior, especially if there's any renal dysfunction. For insulin, the usual practice is to give either 1/3 to 1/2 of their usual morning dose of intermediate-acting insulin, like NPH,
Or switch them to an infusion?
or switch them to a sliding scale or a variable rate insulin infusion. That's often the safest approach, especially for type 1 diabetics.
And what about IV fluids? We see a lot of residents wanting to hang D-Fi.
That's a common mistake. You do not use dextrose-containing fluids as your primary line. The stress of surgery itself, the catecholamine release, is going to raise their blood sugar. You start with a balanced salt solution, like normal saline or Ringer's lactate.
You only give dextrose if?
You only give dextrose if the blood sugar actually drops low, or if you are running a specific combined glucose, insulin, potassium, or GIK infusion. But never use dextrose as your maintenance fluid blindly in a diabetic parturient.
And you're checking the sugar how often?
Hourly, at a minimum. Hourly intraoperative blood glucose checks from a finger prick or an arterial line.
Let's talk about anesthesia for labor and delivery.
Regional anesthesia, specifically the epidural, is the absolute hero here. It's the best thing you can offer these patients.
Why is that?
Pain causes a massive catecholamine release. Catecholamines raise blood sugar. A good working epidural blunts that stress response beautifully, which helps keep their blood sugar stable. It also improves intervillous blood flow to the baby. And, of course, if they suddenly need an emergency C-section, you can just top up the epidural and avoid a risky general anesthetic.
Right, which we want to avoid because of the airway and aspiration risks.
Exactly. Stiff joint syndrome makes intubation hard. Gastroparesis makes aspiration likely. Plus, the act of laryngoscopy itself causes a huge sympathetic surge, which can spike the blood sugar dramatically. GA is a last resort.
But if we're doing a planned C-section, spinal anesthesia is usually preferred.
Spinal is the gold standard for an elective or semi-urgent LSCS, yes. But you must be cautious. Preload them carefully with non-glucose fluids. And be very aggressive with treating any hypotension because, as we discussed, their autonomic system might not be able to compensate on its own.
What if we are forced into a GA? Let's say there's sudden fetal distress, a failed regional block, or severe coagulopathy.
Then you have to be prepared. It is a rapid sequence induction and RSI with cricoid pressure, no question. You must assume a difficult airway is likely, so have the video laryngoscope and a bougie or an LMA for rescue right there, open and ready. And tell the neonatal team to be ready for a potentially depressed baby.
Okay. Moving to part E, postoperative and ICU care. The baby is out. The placenta is out. What happens to the mother's insulin requirement?
It crashes. This is very high yield for your exam. The placenta was the factory producing all those insulin resistance hormones like HPL. Once the placenta is delivered, that factory shuts down. Insulin sensitivity returns almost immediately.
So if we keep them on the same intraoperative insulin dose,
You will kill them with hypoglycemia. It is a medical emergency waiting to happen. You must immediately reduce the insulin dose, usually by at least 50%, or in many cases, stop the infusion entirely and switch to a very cautious sliding scale.
what about the GDM patients?
For most GDM patients, they often need no insulin at all in the postpartum period. Their blood sugar just returns to normal.
And breastfeeding, does that affect things?
Yes, absolutely. Breastfeeding burns a lot of calories and can increase insulin sensitivity even more. So you have to watch carefully for maternal hypoglycemia, especially around feeding times.
And when would one of these patients need to go to the ICU?
DKA is an automatic ICU admission, no question. As we said, it can happen at lower blood sugar levels in pregnancy. Other indications would be coexisting severe preeclampsia or HELLP syndrome or any kind of unstable cardiac status. It requires a multidisciplinary approach.
Let's wrap this up with Part F exam integration. We've covered a ton of facts. How do we package this for the examiner? What are some of those Viva traps they like to set?
Okay, trap number 1. Can we use tributaline for Glycosylation to stop preterm labor? The answer is an emphatic no, or with extreme caution. Beta mimetics cause severe hyperglycemia and can precipitate DKA.
Track number 2.
How do you diagnose GDM? You need to be able to briefly discuss the 75-gram oral glucose tolerance test criteria, mentioning the thresholds fasting over 92, 1 hour over 180, 2 hours over 153 shows. You know the details.
In trap number 3, we mentioned this one before.
Why is the baby hypoglycemic? You have to be able to walk them through the Peterson hypothesis and the fetal hyperinsulinemia mechanism. Just saying, because the mother had high sugar is not a good enough answer.
In terms of structuring the 20-mark long answer, what's the winning formula?
Structure is king. Follow a logical flow. Definition, then classification, then pathophysiology, making sure to cover both maternal and fetal effects, then go through the anesthetic management chronologically. Pre-op, intra-op, post-op, if you can, throw in a simple flowchart for the intraoperative glycemic management algorithm. That always scores bonus points.
Any final advice for the exam candidate listening to this?
Yes. Don't get lost in the weeds of endocrinology. Always bring it back to the anesthetic implications. Why does the stiff joint matter? Because it affects the airway. Why does autonomic neuropathy matter? Because it affects hemodynamics and hypotension. Why does high sugar matter? Because of infection, wound healing, and diuresis. Always connect the pathology back to your practice in the operating room.
And a final thought to leave them with, something to chew on.
Think about the long game. There's something called the Barker hypothesis, or developmental programming. The idea that the fetal environment programs that baby's metabolism for the rest of its life. Fetal exposure to hyperglycemia seems to program that child to be more at risk for obesity and type 2 diabetes later in life. So by managing the mother well, you are, in a very real sense, practicing preventative medicine for the next generation.
That is a very powerful way to look at it. Thank you for that masterclass. To all the listeners out there preparing for exams, good luck, study the triad, watch the airway, and whatever you do, don't just blindly give dextrose.
Good luck to everyone.
That's it for this deep dive. See you next time.